Good afternoon, and welcome to What's Up Doc. My name is Tia Teriak. What's Up Doc is a monthly lecture program of the Concord Hospital Trust designed to bring you the latest healthcare information, treatment options, and providers available in the Concord Hospital Health System. We'd like to stop and take a moment to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up Doc. The Walker Lecture Series was established here in Concord in 1892 as a result of a bequest in the will of Abigail Walker. The Walker Lecture Series offers regular lectures on history, literature, art, and science, as well as dramatic, musical, and literary performances. All events are free to the public and are held at the Concord City Auditorium. We encourage you to check out their website at walkerlecture.org to view their calendar of programs. Today's What's Up Doc program features Dr. Ann Cabot from Concord Hospital Neurology. Dr. Cabot's topic is the many faces of multiple sclerosis. I'd like to share a little bit about Dr. Cabot with you. Dr. Cabot completed medical school at the University of New England College of Osteopathic Medicine. She then went on and completed her residency at the University of Massachusetts Medical School and then completed a fellowship at the University of Massachusetts Medical Center. Dr. Cabot is board certified in neurology, and she joined the Concord Hospital staff in 2011. Please join me in welcoming Dr. Ann Cabot.
Thank you. Sorry, I won't grab your chips. I'm just grabbing the clicker. So thank you guys for coming in today. I'm going to keep my mask on in hopes that you can hear me okay. And I'm really honored to be here and talk a little bit about neurology and multiple sclerosis and hopefully answer any questions you might have. So with that, I'll flip this around the right way and get going, I hope. There. So I just thought because neurologist hasn't been here for a little while to do What's Up Doc, I'd give you a general overview of what we do in the clinic. So we have a fairly big group, and neurology, as you can imagine, is a really diverse field. So we take care of the brain, the spine, optic nerves, muscles. So we see a variety of diseases and different conditions. So we have patients with vascular disease, so strokes or different types of vascular issues, dementias, memory disorders, lots of different types of dementias. So movement disorders, so people who get a tremor, twitching, things like that. Seizures and epilepsy, very big part of neurology. Headache, a very big part of neurology. There's many different types of headaches. Neuromuscular disorders. And then I put myself at the bottom here, demyelinating disease. So demyelinating disease is one part of neurology, so I'm really going to narrow my scope down to my passion, which is multiple sclerosis. So I don't mean to diss my colleagues, but we can bring them back if we want them to talk about epilepsy or strokes or something like that. So, and today's mission, if we choose to accept it, is to talk about MS. And I think it's a really unique topic, and it's a disease that is going to keep us humble forever. So we could stay here and talk about it all day, but I will try not to bore you. And the reason I chose a snowflake as my picture is because, not only because it's winter, and I really had to be careful walking here in my real big girl shoes, but because MS is so different for our patients that we really call it a snowflake disease. So by the end, hopefully you'll understand a little bit more about why I use the snowflake as our picture today. So we're also going to talk about some of our patients. So I put a couple cases in there today. And you guys can help keep me on track, because if I get excited, sometimes I might go off topic, but keep me focused on that. And then I want to talk about how Concord Hospital has been a really special place to work. And I feel really lucky to be here. And I want to thank you all for that, because you guys make this such a special place for us and for our patients. And I drank a lot of caffeine this morning, so if I feel like I'm going too fast, just tell me to slow it down. So MS is a disease that impacts the central nervous system. So when we say the central nervous system, we're talking about the brain, the optic nerves, and the spinal cord. Just those three things, okay? So, but that's a lot of geography, right? So, but once the nerves leave those areas, then it's not a disease of MS. It's not a central nervous system disorder. So that sort of helps localize where we are in neurology. But again, it's a big territory, all right? So I thought I'd tell you about a little bit of epidemiology about MS. Who gets MS? And I'm sorry if I'm in your way. So typically, MS diagnosis is between the ages of 15 and 45, but there are cases as young as 3, and I have diagnosed patients in their 70s. And to be honest, some patients are diagnosed at autopsy, and they didn't even know they had MS. So it's a disease that will keep us jumping, right? But if someone's younger or older in the spectrum, we tend to think of what other disease processes might be going on. What else could we be missing? The typical patient, usually between 15 and 45 or 20 and 50, something like that. So women outnumber men by a long shot in this disease, which is fairly typical. And most of our patients, so 85% of our patients, are diagnosed with a relapsing form of the disease. Within 10 years, half of these patients may develop secondary progressive MS, and I'll get into that a little later. But what we're trying to do is to prevent disability down the road with our treatments. So when we look at the territories, people who are affected by MS, it's much less common near the equator and much more common the further away you get from the equator. So in New Hampshire, generally speaking, the risk is about 1 in 850 people if you don't have a direct relative. So it's not an uncommon disease. We know there's over 1 million people in the United States with MS. We have, I think, about 1,100 patients with a diagnosis of MS that we see in the neurology clinic. So this is a super exciting field in MS, but the hard part is we really don't know what causes it, which seems crazy, but when you think about it, we don't know what causes a lot of our diseases, but we have a lot of clues, and I'm always amazed at the researchers who figure this stuff out, right? So we know there's a genetic predisposition, some kind of genetic predisposition. And then there are other things that need to go on that trip up the system and cause MS. That's sort of how I think about it. I think about it like Velcro. You know, if you have Velcro and you only have one side of the Velcro and you don't have the other side, it won't stick to anything. But if you put those two sides together, it kind of sticks. I feel like MS is like that. You have to have the predisposition and then come across some other thing. So I don't know if you even saw, it was widely published, the article about Epstein-Barr virus being a trigger. Did anybody see that in the paper recently? Yeah. So that is, science, that was big and in the news. Now we've known that since the 70s, but the data keeps getting better and better and better. So I feel like our immunologists who have been really busy, with the pandemic but every time they learn something from another infectious disease or another virus or another, immunological disorder, sometimes that can apply to MS as well. So we're learning so much about what this comes from. But to be honest, we still don't know. So probably an infectious agent could be a trigger. Toxins are in our environment potentially linked. So like if you look at smokers, people who smoke are twice as likely to get MS than non-smokers, so in some studies. So obesity has recently been found to be a predisposition, and low vitamin D has long been linked as potentially a trigger as well. So what happens is you get this abnormal immunological response, and then these triggers induce like this autoreactive population of cells that then trigger an inflammatory response in that central nervous system. So there's a whole lot of things that have to happen in order to get MS. So what is it? What happens in MS? So here I have a picture of demyelinating areas. So if you have a neuron, I always think of us sort of like electrical systems. When I explain it to my patients, I say, when you have an action you want to potentiate, let's say I want to raise my leg, I have all these thoughts that I have to get that signal down to my foot. It's a long way. It's pretty amazing how fast it works. So it speeds along through the neuron, and the neuron is coated with myelin. It's a fatty substance, so fats are good in this case. And because that myelin sheath is there, the signal can travel really quickly through our nervous system. When it has episodes of demyelination, what can happen is either the myelin is disrupted, and if it's significant enough, even the neuron is disrupted. So you have areas where that signal just doesn't go quite as quickly. So that can lead to problems. So this is triggered by inflammation. The neuron gets rattier looking. Sometimes there's healing. So if the neuron's intact, sometimes the oligodendrocyte, the cell that makes myelin, can remyelinate the area. But sometimes the damage is significant and there's less healing. But we can see it even on immunohistochemical slides where you see these blebs or where the neuron has actually been disrupted completely in that slide. So that's basically what's happening in a microscope. So this is not something we're doing in the office, don't worry. This is an actual autopsy slide of a brain, and what we're looking at here is this is the white matter, this is the cortex, so we're looking at the gray matter. These are the fluid-filled ventricles, so those areas make spinal fluid. And this area here should be kind of the same color as that, right? So this is an advanced case of multiple sclerosis, and I have no idea why this patient was in this slide. They could have had a car accident, probably, I don't know. But it does show very much the scarring that we typically see in a patient with advanced MS. If you had a gloved hand and you ran it over that slide, or that slice, it would feel hard, like a scar. So when I describe it to patients, I say it's like when you cut your skin and you get like a little bumpy scar, sometimes it is hard, and it doesn't transmit that signal quite as well. It's not like a stroke in the sense that it's completely gone most of the time. There can be areas that recover, and I think that's sort of the positive side that we always want to get back to. All right, so the disease has different stages. So we know that especially early in the disease, there's more inflammation. So our younger patients who get MS, they have a lot of inflammation. They get more attacks. And then as we get older, through the course of MS, there tends to be fewer attacks. So they don't have the ups and downs of relapses. So a typical relapse might be someone who comes in with like, oh, my eye hurts, I've lost vision in my eye. We treat them either with steroids or some other kind of medication, and the vision typically comes back, okay? It may not be perfect. It may get a little wonky when they're hot, overtired, overstressed, but it does typically come back. And so they have these ups and downs. That's the relapsing, remitting part of MS. But then, and they can regenerate. But then as time goes on, that gets less, and this gets harder, and the degeneration sort of picks up. This is the area where a ton of research is going on right now because we do have, fortunately for me, tremendous treatments for this stage of the disease. There's some treatments for this stage of the disease, but we have room to get better. So this is where we're going. So, so this has a lot to do with aging and inflammation and healing and all that. So these are things that are really important to us. So this is a list of symptoms, and it can be a little overwhelming because you're like, well, all right, you pretty much listed everything, but symptoms of MS are typically invisible. So a lot of our symptoms, like a numb foot, a blurry vision. So if I was looking at you and you had a blurry vision or a numb foot, I couldn't see that. You would have to tell me about it. So a lot of what we do in the office is taking a history, getting the story from the patient. It's a lot of what neurology is, to be honest, is history taking, listening to the patient's story, and then trying to figure out where these symptoms might be coming from. A lot of patients with MS, when you first meet them, they say, I feel like I'm crazy because I had this thing for 2 weeks, and then I had this hand was numb for 2 weeks, and then I lost my vision. So they've had little things that have gone on time and again, and then they got better because the inflammation went down, and so you really have to kind of put the whole story together. So typical things that you might see in a person with MS would be weakness. That is one visible thing for some patients. They might have like a gait disorder. They might drag their foot a little bit. They might need a brace or a cane. Maybe they have some balance issues. Those are sort of the visible signs of MS. But sensory symptoms can range. So we can have patients who just have numbness, or they might have discomfort. Maybe their foot is burning, right? Maybe they get a zippy-zappy feeling when they flex their neck. Like it could be something like that. Mood disorders are more common in MS than in the general population, so we talk a lot about mood disorders in the clinic. So we talk about depression, we talk about anxiety, we talk about sleep disorders and where to get help and all those things. Coordination, so just fine motor skills, ambulation, work tasks, things like that. Visual symptoms are very commonly the first symptom that gets a patient a diagnosis because a lot of people don't ignore it when they lose their vision. Like if you had blurry vision or double vision, you're probably going to go get help. Whereas sometimes with a numb foot, you're like, oh, I must have thrown my back out, and it'll get better. But vision is often the first sign of MS. Patients, because the MS can involve the brain and the spinal cord, patients can have bladder and bowel symptoms, so urgency, frequency, incontinence. So we work with a lot of that. Cognitive issues, cog fog is a lot of what our patients talk about. Fatigue. Fatigue is one of the #1 complaints of our patients with MS. It's not the first thing you think about when you talk about MS. And I think the other thing to think about is when we diagnose a patient with MS, they have it for life. So it's not something like it's hard to wrap your brain around when you're 18 years old, right? So when we diagnose someone with MS, they're going to have that for life, like diabetes or any other chronic illness. So we want to make sure that we have a good ability to communicate with them, that we have the ability to educate them or show them where good educational resources are, and that we also provide them with a team of people to help them. So if I'm not the one treating their bladder and bowel symptoms, that I talk to our urology friends, and then let's say they're 18 and they're in college. So how are we going to help them get through finals? Then they get out of college, they get their first job, then they want to get married, then they want to start a family. How do we talk about family planning, while you're on disease-modifying medication? So there's all these things. And then later in life, how about when I'm, getting ready to retire, or I go through menopause, or I have other medical conditions, right? Because as we get older, we tend to accumulate high blood pressure, things like that. So we really do try to pay attention to the whole patient and remember that they're going to have this for a long time. So one thing patients hate is when you say this, it says, oh, you look so good. Because it's very hard for patients when they have fatigue or they feel dizzy or they're off balance and they just don't feel great for people to say, you have MS. And it's very hard not to when they do look great to say, oh, you look great, And the patient's like, they don't feel validated. So I always try to recognize that I understand that they have symptoms, but sometimes it's hard to remember because they do look on the outside perfect. So it's always good to remember when you have a patient or a friend or a partner or a relative with MS, you can sure tell them they look great, but sometimes you may be, how are your symptoms or something like that, so that you can voice some understanding that you get that a lot of them are really invisible. So I swear that's not it. Yeah. Oh, sorry. I'm a trigger finger happy person. So I thought I would share a couple of patients just to give you a sense of what typical patients are that come into the office. And to be honest, there is no typical patient, and that's the hardest part. Like, we could stay here all day and I could tell you about my amazing patients that we see every day. So this was someone, I just pulled up the MRIs, who was, she had a history of sleep apnea and obesity, and she came into the office with some right-sided eye symptoms and some numbness and tingling on the right side of her body, okay? When she thought back about it, she actually had some eye symptoms that had occurred a while back, but they had resolved in a couple of months. She never really sought care. And when we did her exam, she did have an abnormal exam. She had some hyperreflexia, so her reflexes were brisk. And when we looked in the back of her eye, it was abnormal on the side where she was having symptoms, so it was pale on that side. And she has a family history of MS. So if you have a family history of MS, you're more likely to get MS. So when patients get worried about that, I say, well, okay, so if you had 40 children, the chances are one of them would have MS. If you have 40 children, you have far bigger problems than one child with MS. So I'm trying to get mine through driver's ed right now, and I cannot imagine getting 40 kids through driver's ed. So, so it is good to know. So, but I would say, have a low threshold to get help, right? Like if you're worried about it, but I think that's the important thing. So if you have a family member and you are having symptoms, then it's probably good to get checked out. So this patient had an MRI. Now, MRI is such a cool tool for us because we're looking at the inside of your brain. I must be a pretty simple person because I still enjoy looking at them with patients. So there are telltale features on an MRI that help us figure out, is this like MS or is this something else, you know? So if we look at this patient's MRI, she has these abnormal findings here. So this is a sideways slice, like that. So this is the front of her, this is the back of her, this is the cerebellum back here, okay? So these are the abnormal findings, and they're around that ventricle here. And I just pulled up one slide because it's not a video, but we would look through all the pictures with the patient. And we also looked at her spine, and I'm sorry, it's a little harder to see. So here's the spinal cord here, and you can see there's a spot there, okay? So that white spot means at some point in time that patient had some inflammation, it left a scar, and then it either healed or it's what's causing the problem right now. So if the patient had some symptoms, she's probably got some optic neuritis, there's inflammation in the back of her optic nerve, and she's had the right-sided symptoms and some spinal cord stuff. So this is a patient who meets the McDonald criteria. So this is something that was from the MS. This is from the MS Society, this side. But these were criteria that change all the time, and it's something that tries to help neurologists when we're trying to figure out, is this MS? Could it be something else? You know, how can we figure out what's the best thing? Because MS remains a diagnosis of exclusion, so it's very important for us to remember that, you know, we've got to make sure it acted like MS, it looked like MS, and it wasn't something else, like, so we do other laboratory tests and things like that. So we go through all these criteria with the patient, and I won't bore you with them, but they're on the MS Society website, which is one of our most wonderful partners. And it helps us share with the patient, this is what we think it is. Sometimes we get spinal fluid analysis, so we do a lumbar puncture and check that too. That not only helps confirm the diagnosis for some patients, but it can sometimes help us diagnose a patient earlier so we can get them on effective treatment. But it also, you know, rules out other things, like make sure we don't have some kind of vasculitis or other infectious disease process if we are worried about those things. Not everybody needs a spinal tap, but we do them. So I don't put this up to say, like, we're going to go through all this, but I did want to just point out that there are lots of other things that can mimic MS. So we do check for these things. Now, when we get the MRI, just because someone has spots on their MRI doesn't mean they have MS. There could be many things that cause spots. That's basically what that MRI says. I mean, the slide says. The other thing the slide says is don't forget about, you know, vascular disease, nutritional deficits that can cause numbness, tingling, symptoms, the same symptoms the patients have, okay? Different infections that we want to rule out. So we do manage these other things as well, but it's just nice to know that we're doing a comprehensive exam, a comprehensive history, to looking for clues for other things besides MS. And even if we diagnose someone with MS, we follow them to make sure it still looks like MS. So if someone has a symptom that didn't look familiar to MS, then we would have to reevaluate our diagnosis. So I feel like it always keeps us on our toes. So what happens to this young lady now? Okay, so she met criteria. Her MRI was very consistent. Her exam was consistent. Her labs were otherwise unremarkable. We did not do a lumbar puncture for her, but we do it for a lot of people. We reviewed the diagnosis, and believe it or not, it's extremely overwhelming to be told you had MS. So in our practice, when we diagnose people with MS, we don't start treatment that day. It's a lot to learn you have MS, because if you took a look at the MS Society website, you would see it is incredibly dense. There's so much information in there. You need a little time to absorb that, okay? So what we do is we narrow it down to a few treatment options, send the patient on their way with information, resources, very good directions about how to follow up, and a lot of times they might need blood work, so we do have to get labs. And we talk about the team approach to how we care for patients. So we often work with a group of us in the clinic so that they always have someone that they can reach out to, you know, they know where to go. Because everybody's a patient. We all know how hard it is to get in touch with your medical team at times, and we don't want them to fall through the cracks, right? Because sometimes the symptoms get completely better. And the last thing I want is for someone to say, well, I got MS, but I'm not treating it, okay? Because we don't want their disability to keep climbing over time. So there's an amazing number of resources. We give them a little chance to absorb the information, then we have them come back in and we pick a treatment together. So So what do we got for treatment? What do you got? That's what they all want to know. What do you got for me? So when I first started, I've been doing this since 2000. I did my residency in 2002. And when we first started, we only had injectable therapies that were FDA approved. Other things we used were not FDA approved. So it was pretty hard to convince people to go on a medicine that they had to self-administer with an injection. But also, some of these patients had side effects. They would have flu-like side effects and things like that, or skin reactions. It was hard for these patients. And I give them a lot of credit because a lot of patients still did the medication. They're doing really well. But some patients were like, the medicine is worse than the treatment, than the disease. So over the years, we have been really lucky. But up until 1993, there was not one medicine FDA approved for MS. So the treatments that were used were all not FDA approved. Patients got a lot of steroids and things like that, chemotherapy. But now, again, thanks to the wonderful research teams and people that dedicate their lives to this, we have over 20 therapies to treat MS. And they're all very nuanced. They're all very different. We can put them in different categories, but they're still very different. So I feel like even if my patient tries a medication and doesn't like it, either because it didn't work or they couldn't tolerate it, I don't feel like, oh no. I feel like I got something else for you. And so the longer I've done this, the more medicines have come out, the luckier I feel for my patients. But the trick is to prevent the damage before it happens. Because you all know that once neurological damage is sort of set in its ways, it's very hard to take that back, right? So I'm still always hopeful, but it is much more challenging. So the other thing that's important is that all medications have risks and benefits, and when we're changing your immune system, we need to make sure the patients understand that and accept that risk. So we're treating your MS, but there's always risk to that. So we always give patients written information to review at home with family. We never want them to feel rushed about making a decision. And the risk can be very variable for different treatments. Picture is very simple, but it kind of goes through, DMTs, disease-modifying therapies, how we think of the central nervous system immunologically in a very basic way. So if I look at the pink thing here, this is my blood-brain barrier. So the blood-brain barrier is tightly packed, densely connected. So hopefully immune things don't cross over, but they do sometimes. So this is the periphery. So I think of this, okay, so the cells are rolling along in your bloodstream. Here's your central nervous system. It's called the CNS for short. And so these just represent different ways in which the immune system, which is a very elaborate system that helps identify what's self from what is not self, right? So if my immune system says, okay, don't worry, that's part of your body, don't attack it, great. In MS, what the immune system did is said, that myelin that covers your neurons is not you, so it has a signal on it to attack it. So when our immune system does that, it sends like a cascade of these autoreactive cells in, it crosses the blood-brain barrier, it goes to the myelin, there's this whole cascade of events that happens, and the inflammation, and then boom, I'm blurry, my vision's blurry, or my leg is numb. So with the medicine, so now that they've elaborated so much more on all the interactions between these different cells, what I think of is opportunity, 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 opportunity to treat. So all these are different ways in which we have been able to interact with the immune system using different medications to treat MS. So the more they learn, the more targets we have to treat. And it's been really rewarding. So these are some of the disease-modifying therapies we had. So I clustered it into sort of their mechanism of action a little bit here. So interferons are our first drugs since 1993. They're all injectables, and they have a modest effect on MS, but a fairly good effect. So some patients, again, here's our snowflake, I could put them on one of these 20 years ago, and they've been stable as a rock ever since. They do great. Awesome. Don't need to change a thing. And then others might have had a new symptom or a breakthrough side effect, something like that. We need to move on. Copaxone's also an old drug, very safe, but can cause skin reactions and sometimes doesn't work for people. So it's one of our lower efficacy therapies, but it's very safe. Some patients find that very appealing. And so, again, some patients do great, and they move on. So Tysabri is a medication that's an IV infusion. If we look at this drug, and I promise I won't do this for all of them, it helps block, this is where its mechanism of action is. It blocks the migration of inflammatory cells into the central nervous system. Pretty cool, works really well. 97% reduction in new enhancing lesions. That's pretty amazing. That was a breakthrough for us. The first oral medications were these sphingosine modulators. It's made from a mushroom. I don't know how they figured this stuff out. I'm just really glad they do. And now we have 4 of them. And they're all a little different. They all act on little different receptors, and so they keep making these things a little bit better and better and better. Fewer side effects when less receptors are impacted. Novantron's a drug I don't use anymore, but it was very effective. Lemtrada, also an infusion therapy. Aubagio is a medication that's a pill patients take once a day, very well tolerated. The fumarates are a big, big class. And then our most popular therapies right now are these B-cell therapies, where they modulate B cells. It's very effective, 98%, fewer relapses, MRI lesions, things like that. So we're seeing some nice benefit from these. And then Mavenclad is a really interesting medication where you give the medication, then the patient has a break, and then you give another dose and they have a break, but then they don't need, hopefully, medication for years going forward. So it's a reconstitution therapy. So we have all these different ways of working, all these different targets. You can see why we don't pick the medicine on the first appointment, right? So not only do we review all these, but we also go through risks and benefits and how you give it and what the lab monitoring might be and all of that. So all these drugs need monitoring, okay? All right, so how's this patient doing? So she chose a disease-modifying therapy and started, but she had to change because she had some side effects. No problem. 20 years ago, I would have been like, oh, bummer. Her vision improved dramatically. She got some IV Solumedrol steroids in the emergency room. It was great. We got her on an exercise program. This patient had some obesity issues and sleep apnea. So that's stressful on her body. We want to make sure we're taking care of the whole patient, right? So if I'm not taking care of that part, I feel like I'm neglecting her general health, right? So I feel like that's a really important part, and Concord Hospital does such a good job at helping us achieve these goals. So I'm very grateful for that. We also offered this patient a stress reduction program, and she took advantage of that, and she loved it. She's actually trying to get her husband to do too. And I think another nice thing is she partnered up with her PCP, her primary care provider, for general health management, which is so important for our patients. So I always remind them, they see me a lot, right? They see me twice a year, sometimes more. And I'm like, don't forget, you need to see your primary care doctor to get your cholesterol checked, your blood pressure checked, all your routine testing and screening. So that's been really good. So, all right, so our new patient's on her way. She's got treatment. She's getting a healthier lifestyle. No new symptoms. We love it. So when we monitor patients going forward, now she's on treatment, I'm going to continue to get MRIs. Right? MRI is a wonderful biomarker for us, lets us know a few things. We're looking at the plaques, like I showed you on her case, but we're also looking for things that might affect the normal white matter. Okay, so we're going to make sure, even if a patient feels great, we still do the MRI for a couple of reasons. One, to make sure our medication is working. We don't want them on a medicine and then have silent lesions, because you can have silent spots, believe it or not, and not know it. So sometimes a patient comes in with like their first event of optic neuritis. They're like, why do I have 20 spots that I didn't know about? Because they're clearly old. And we're like, well, they were in an area of the brain that you didn't, it wasn't a sensory area, it wasn't a motor area, so they just didn't have any symptoms. So the MRI is really important, because if we have them on a treatment and we still see new lesions, we are probably going to change to a new therapy, because our medications just keep getting better and better, and we get pickier and pickier. And why would I want new lesions for my patient with MS? So we also look at atrophy. We look at gadolinium. So when the patient's in the MRI, they get contrast. If the contrast crosses that blood-brain barrier, it shows up as an enhancing lesion, and then we know at the time the patient's in the scanner, their disease is active. We don't have good control of their MS. So we use the MRI as a biomarker, one of them, for treating patients to make sure we have them under good control. So let me show you what bad control is. So if someone came in and they had all this white stuff, this is after they got contrast. So they went into the MRI, they had their MRI, they came out, they had the IV with the dye, The dye crossed the blood-brain barrier in all these spots. So this is a patient with poor control of their MS. So then after treatment, this is our goal, is we have no gadolinium enhancement. This is just one of the series. So when a patient goes in the MRI, they're in there for 45 minutes for a brain MRI, another 45 minutes for a spine MRI. They go through a lot of different series. So we look at a lot of different views. We're looking, this way, all over the place. And that helps us localize the lesion, make sure we got the size right. We have great neurology here, wonderful MRI. They've been amazing at working with the MS protocols. They've been terrific. They don't mind when I call and ask them to review something with me, and I'm always grateful. So, but this is what our goal is. We don't want any new enhancing lesions. Okay, so we want to get that under control. All right, so let me tell you about a different patient entirely. Okay, so this is a person who's 57 years old, and she's had MS for 30 years. Okay, so 30 years ago, we didn't have the benefit of all of the nice medications that we have now. So this person didn't have a lot of that. So when we look at this person's MRI, we're seeing larger ventricles, more, I'm sorry the contrast isn't quite as good on this slide as I had hoped, more diffuse plaquing or MS lesions. And this is why I don't tell a patient you have 5 lesions versus 20 lesions, because some of them are very, very tiny, and then some of them can just sort of morph together. So I think it's really, you've got to compare year to year to see if there's been changes. And there's thinning of this structure called the corpus callosum, pretty dramatic thinning of that structure. And we see multiple lesions in the spine. Am I doing something? I don't think so. So she has quite a heavy burden of disease. So early on in the course of her MS, she didn't have the benefit of really aggressive therapies because we didn't have them. But now, hopefully, we have. Sorry about that. Dun, 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 dun. If I could juggle. Oh, it's not me, it's a signal. See, there you go. I could push a couple buttons. It wouldn't be a presentation without some technical fun.
Well, the great thing is Sam can do great splicing.
Okay, good. So what are you guys doing this weekend? Oh my gosh, that's great, thanks. All right, I'm gonna move a little faster. All right, so this patient, our other patient really wasn't having a lot of symptoms. Treated early, treated aggressively, treated well, doing great. This person actually has quite a few symptoms that are long-standing. Okay, so she has cognitive issues. She has spasticity, which means her muscles are tight. She has weakness. She has low vision. She has fatigue, depression, urinary incontinence, and a gait disorder. She has loss of sensation in her hands and lower extremities, and she has financial stressors. She has emotional stressors, and she has caregiver stressors, okay? This is not an uncommon situation for us to see because we have patients for life. This is the family practice of neurology, I like to say. Like, we do care for these people for a very long time. What do I do with all that, right? This is where I feel like our Concord Hospital team excels because we partner up with really good people. So I can't say enough about how wonderful I think the urology department is here. They make our team look good, so I love them. So we use urology, and they help us with the patient's bladder issues. So we know when it's time to send the patient to urology. We work with mental health. We have someone in the office who's been working with us for 10 years, helping us with some mental health issues. But sometimes we have to work with the primary care provider or mental health specialist. We work with neuropsychology to help with cognitive issues. So that can be to get baseline testing, or for work, like if someone's working and they're having struggles, we might have to get neuropsychology testing to see where they're at with that. We use a lot of rehab services. Rehab services are such a cornerstone of MS treatment and wellness. So this is how we get patients back on their feet, how we get them into home exercise programs so they don't have to just keep going. But not only do they help with sort of the physical part, but they can also help with some of the cognitive part of that. Social work and VNA comes into play. We use a lot of physiatrists to help with mechanical issues. So our patients often need bracing, wheelchairs. They have spasticity. Sometimes we use backlift and pumps to help with lower extremity spasticity. We partner up with physiatry. Sometimes they have mechanical issues from their long-standing foot drop. They might have a back, issue. So we work with physiatry, orthopedics, those guys. We have wonderful neuro-ophthalmology who's retiring. Our radiologists are, again, fantastic. And then bracing specialists. So you can see that this is a very different type of patient, and believe me, we have everything in between, right? So additional resources for patients, the National MS Society, the Multiple Sclerosis Association of America, the MS International Foundation, exercise programs, Concord Hospital Wellness Program and Granite VNA, palliative care, and elder services. So these things are invaluable to us, and we are very happy to have them. So, with all these symptoms, our patients become pretty complex. Sometimes we're multiple medications to treat symptoms. So if they have depression and spasticity and incontinence and all those other, we're treating that and their MS. So it can be a juggling act. And then we always want to remember, if someone has severe MS or difficult MS, and they might have more financial strain, maybe they're not able to work, right? So they now need rides to their appointments. Maybe there's caregiver burnout at home. I think it's really important to address it up front, because sometimes roles change. Like maybe I was the one who was working and my husband stayed home with the kids, but if I got sick, now my husband's working, so it's just all these things that kind of come into play. So it's really nice to have the available resources to help patients with those things if we can. But this person obviously needs more services than our initial patient, who needed no services except nutrition and PCP and wellness, right? So our hope is, with our new therapies and more attention to detail, especially with our new treatments, our patients won't have to deal with a lot of these things, but we still do need to address them very carefully. So the patient doesn't have any new lesions on her MRI. She remains on therapy. She's very motivated to get well, which is the best thing. I love when patients come in and they're psyched to get better. So, but it is a struggle for a lot of the folks. So I wanted to show you a picture of some of our team. I couldn't get to everybody because, as soon as we want to get together, there's like, there's a patient, there's a call. So I feel bad. This is not our whole team. But I wanted to shout out to these guys because they've been amazing. There's a lot of calls. There's a lot of putting things together. Dr. Rybacher, Georgia Plamondon, and myself. And then we have nurses. They are motivated. They get MS certified. They know the disease inside and out. It's a lot of work for them, but it's a labor of love. So I really wanted to share that with you. So now I'm going to just tell you a little bit about some of the fun stuff we do in the clinic. You tell me when I need to stop. But I didn't know how much time I had. So I'm fine. Okay. So the pandemic was stressful for a lot of our patients. No joke, right? So how do we manage patients when we're not seeing them in the office? How do we help them with social isolation? How do we help them keep exercising and eating right during this whole time? So we try to identify issues patients have and then try to find what are the obstacles to wellness. So just like MS can make speed bumps in our nervous system, other things can put speed bumps in their wellness. So distance. So I noticed a lot of our patients, we offer wonderful classes, but they're like, boy, I'm 45 minutes away or I'm an hour away from the hospital. Coming to the office is hard for me because I have to drive all the way home afterwards and I'm tired. So we got a lot of our classes on Zoom. Cost can be a big issue for a lot of our patients. So we got a grant and we're very grateful. So our classes are free to our patients. A lot of patients are worried about COVID, so Zoom is fabulous. So we love it. And then we try to help them with motivation. So we have a mindfulness-based stress reduction class, which probably we could all take. But it's an amazing class. It's based on the Cabot Zinn model. It's an 8-week class, and it's been Zoom-based. And our teacher is great. It's Jean Ann Whittington, and she's an accredited teacher. It's no cost to the patients. This is a very labor-intensive class. It's usually can cost a few $100s for patients, so that's covered. They do the class with other MS patients or care partners, and I love adding that in because sometimes a care partner is the one that's feeling the stress. And then how can it help? So we know through studies that mindfulness-based stress reduction can help in a lot of ways. So it can help with mental clarity, better sleep, attention, focus. And there's even been studies that show it increases your cortical thickness in certain areas of your brain. So it's pretty impressive. And I always remind my patients, no side effects. Okay, so no side effects. So not like a lot of things we do. And sleep is great. Like sleep is an important thing. Anxiety management is an important thing. We have an art class, which we just started. Beverly's the teacher. She's one of our nurses. She's brilliant. And I just put up pictures that our patients did. I'm like, oh my gosh, I can't make a stick man figure. And I'm like, you guys are phenomenal. And to be honest, it's just a laugh riot. It's very COVID safe. There's only 4 people in a class at a time, masked up. But I'm just enjoying watching the joy on the people's faces when they create anything and have fun in this kind of environment. So it's a very positive, fun evening out for patients, and she's doing it once a month right now. And it's just started, so we've only had a few sessions, but it's been a blast, like giggling, laughing, enjoying, things we love our patients to experience. We've had MS yoga for years. MS yoga is great because a lot of our patients have tight muscles or balance issues or core strength weakness. Patients can do this seated, which is wonderful. They can do it on Zoom or in person. The teacher's been doing it for a long time, and she's lovely, but it really helps with energy. Any exercise helps with energy. A sense of community, you know you're not alone, and it's just great to help limit medications, because I don't want to just keep giving medications to patients to treat symptoms. I want to try to get away from that if possible. So the medications we give for spasticity cause fatigue. The number 1 complaint of our MS patients is fatigue, right? So I don't want to perpetuate the cycle. So in summary, I do think that MS will forever keep us humble. We keep learning every day. I'm always grateful for the research that's published and stay on, always coming out. Like, it's an amazing area of intense research. And the outlook continues to be brighter all the time. It's a very optimistic time to work in MS. I never would have guessed when I started this journey that I would have all these things to offer my patients. So I'm incredibly happy about that. This is an incredibly heterogeneous group of folks. So they are our snowflakes, and they have some common features, but they're all very unique patients with some similar stories. And there's a lot of ways we can continue to support the MS community. It's hard here in New Hampshire because there aren't a lot of services for patients, and sometimes they are very spread out from each other. So geography can be tricky for them. And we're very proud to be here at Concord Hospital because they partner up to help the whole patient with those support programs that I just mentioned, and help get the best outcomes for our patients. So it really is a wonderful place to be involved in MS care. And I thank the hospital for that. So.
On behalf of the entire staff of the Concord Hospital Trust, thank you for joining us today for What's Up Doc. We hope today's presentation has provided you with a clearer understanding and additional information regarding MS. We also hope that you will share what you've learned and share What's Up Doc with family and friends. This session has been videotaped, and we upload the videotapes to the Concord Hospital Facebook page, Concord Hospital YouTube page, and also the homepage of the Concord Hospital Trust. And we maintain a library of all of our programs. So go in and take a look and see what you can learn about. Next month, What's Up Doc will welcome Dr. Raza Sharif from the Weight Loss Institute of New Hampshire from Concord Hospital, Laconia. Dr. Sharif and his team will be here to talk about the latest in weight loss options. Thank you, and go out and enjoy this wonderful and unusually warm February day. Thank you, everyone.